in practice of orthopedics and sports medicine over in New Windsor back in 1996. He and I grew the practice. I am now still practicing hand surgery, but I'm also the chief medical officer here at Montefiore St. Luke's Cornwall Hospital. So I enjoy wearing those hats. Still see patients in our same old office out on Route 94 in New Windsor with my associates at Crystal Run now, in addition to performing administrative functions here at the hospital. So welcome tonight. And again, interrupt if you have any questions whatsoever. So what is arthritis? When we talk about arthritis, you break it down to its Latin origins. Itis just means inflammation, like when we talk about tonsillitis or appendicitis, and arth is the description of a joint. So it's really just simply inflammation of a joint, no more, no less. So what is a joint? Again, when we talk about arthritis, this is inflammation in a joint. You can't get arthritis in the middle of a bone, and you can't get arthritis in the middle of a muscle. You get arthritis inside of a joint. So tendons and ligaments, this is a picture of a joint here. What you can see here is there's a bone up on top, there's a bone down on the bottom, that's the white stuff. And then you see the pink stuff that's supporting it. The blue is on the inside of the joint and the pink is on the outside of the joint. And if you look at that gray zone that's capping the bone, that's called cartilage. And that is where arthritis takes place. Ligaments hold bones together so that they don't go sliding all over. This is the reason why my finger doesn't go sideways, is because there's ligaments or rubber bands on the side that prevent the finger from going that way. And then the tendons are the ropes that actually move the fingers, that bend and extend them. And those are what your tendons are. Right. So what is cartilage? Well, as I like to say to my patients, it's the same thing you see when you pull apart a chicken leg, or the turkey leg, perhaps more appropriately. Here we are a couple of days after turkey. When you crack open the knuckle of your turkey thigh, what do you see? You see some shiny white stuff. And that shiny white stuff is the Teflon coating, I like to say, on the inside of your joint. And what it allows is for your joint to glide smoothly when you try to move. All right. And arthritis is when that same beautiful, gorgeous, white, shiny stuff that you see on the left side with a scope inside somebody's wrist begins to become frayed. And that's what you see on the right side. This is early arthritis, where the floors have been scuffed up. And now you have all this rough stuff. And you can almost imagine how that stuff on the right side, if you tried to move over that, it would be like shuffling your feet on a shag carpet, versus on the other side where you're skating across an ice rink. All right, so you can start to picture why arthritic joints begin to feel stiff and why they don't feel like they move very well. And in fact, that cartilage not only frays, but eventually it will wear away until you look at the picture on the right side. That's the end of somebody's femur who has very significant arthritis. And you can see the shiny pink stuff on the right. That's bone. That's bone that's been completely denuded of the shiny white stuff. And you see a little bit of the shiny white stuff on the left side of that distal femur, but on the right, you can see where that cartilage is worn away. And this person is getting a knee replacement, which is why we have such beautiful exposure of their joint. And how does arthritis feel? That's why people, when they first wake up in the morning, they say, I just can't move. But once I get moving, I'm okay, right? The Tin Man syndrome, the idea you got to lubricate up those joints, get a little grease in there, get the fluid moving around. So that even an arthritic joint that doesn't have perfect cartilage, you can actually move fairly well. And there's two kinds of arthritis, basically, osteoarthritis and rheumatoid arthritis. And osteoarthritis, that's a genetic condition. Thank you very much, God. You've programmed me to have my cartilage deteriorate over the course of years. Sometimes maybe because you had a trauma, right? You had a football injury in high school, or you dislocated your finger, when you're in your 20s, and now when you're in your 30s and your 40s, and you scuffed up, you traumatically roughed up that beautiful shiny white stuff. That can be osteoarthritis. That's different than rheumatoid arthritis. Rheumatoid arthritis is actually an autoimmune condition. This is where your own body begins to mount an inflammatory response against your own cells. It starts to think your own cells shouldn't be there, and you mount this inflammatory response. That's why when you see all those commercials for drugs for rheumatoid arthritis, they talk about people who have underlying infections shouldn't or have to be very, very careful. Why? Because it suppresses your immune system. Rheumatoid arthritis is an overactive immune system attacking your own body. The drugs for rheumatoid arthritis suppress your own immune system so that you don't do that so terribly. So again, osteoarthritis is either genetic or traumatic, and if the lining of your joint wears away, and as the lining begins to wear away, your joint becomes a little unstable, and you start to grow little spurs around it to support the joint in response. Rheumatoid arthritis is when your own immune system begins to attack the soft tissues around your joint. And as now the joint becomes unstable, it begins to erode away the cartilage. So people with rheumatoid arthritis, their x-rays look fairly normal early on because it's the soft tissues that are wiggly wobbly. An osteoarthritic person early on, their x-rays already show abnormalities. So again, on the left is what a normal joint looks like with a beautiful gray lining inside that blue joint. And osteoarthritis, that gray layer has worn away. And you can see the bones just rubbing on each other. In rheumatoid arthritis, way over on the right, the cartilage isn't the first to go. First, the joint gets red and swollen and painful, and it hurts to move it. But if I take an x-ray, your bones and your cartilage actually still look okay early on. The deterioration happens later.
That's when I have to click on the screen.
There we go. All right. So again, osteoarthritis. This is what somebody with osteoarthritis looks like. You'll notice that the tips of the fingers have lumpy, bumpy things. There's some twisting and turning. But if you look at the bigger knuckles, the knuckles down and through here, they actually look relatively normal. And that's the pattern of osteoarthritis. Osteoarthritis starts in the smaller knuckles, and only very much later, if ever, does it impact those bigger knuckles in the hand. Fingers in rheumatoid can start at those small knuckles, but you start to see that there's nodules now even in the bigger joints if you look further back into the hand. And again, as we talked about, if you look at osteoarthritis, you'll see how on the right wrist, the wrist that has the right over it, look at the difference. There's no clear lines between the bones anymore. But if you take a look on the right side, again, you'll start to see how the fingers have lost their spaces. Small joint changes in OA. This is what you can sort of see. We call these Heberdine's nodules, those big lumpy, bumpy things that develop around the small joints. And then you can also develop things called mucus cyst. It almost looks like a blister that's on the back of your finger at the level of the small joint. And it is kind of a blister. It's a blister from your joint. It actually is the inflammatory fluid inside of a joint that pushes out to create this little cyst, which can rest just underneath your skin and give you this appearance of a blister. But that blister actually goes all the way down to your joint. And it's not the blister that hurts, it's the underlying arthritis, which is giving you the pain. Now, one of the joints that's very commonly affected in an osteoarthritis is the joint at the bottom of your thumb. Going by the names on the screen today, I have a lot of women over the age of 45 on the screen today. And this is an arthritis here at the bottom of your thumb. 45% of women over the age of 45 do have some component of basilar joint arthritis. This will bother you when you grab something, right? When you go to grab a plate, a stack of dishes out of the cabinet, or you go to squeeze something or hold a book like this. That's really going to aggravate you as you aggravate the bottom of your thumb. And that's, again, super duper common. All right. And the options for treatment, simple. We start off with doing some braces to support this painful joint a little more aggressively. We can put a little cortisone in there. Why? Inflammation is part of your pain. And if I can take down the inflammation, I'm not going to cure your arthritis, but I'm going to take down your pain. So a little bit of cortisone inside your joint can temporarily lower that inflammation and make someone's arthritic joint more comfortable. And then, of course, eventually over time, if this particular problem does not subside, that is, the brace doesn't help it, pills for inflammation don't help it, injections for inflammation don't help it, therapy is not helping it, then we have a surgery. And the surgery is to physically remove the bone at the bottom of your thumb, because by removing the bone at the bottom of your thumb, we remove the source of your pain. So again, it's a big operation as far as hand surgery goes. It's about a 6-month recovery, but it can be very, very successful at taking away a painful arthritic joint at the bottom of the thumb. And again, when we take a look at this joint, what happens if you look on the left, picture A, that's kind of a normal looking joint. You'll see there's a big space between the long bone and the bone, just the boxy bone just underneath it. But in the next picture, B, you'll see the space starts to look narrow, and C, the space looks even narrower. And by the time we get to D, there's not much space in that joint at all. And that is when it's really, really painful. So what do? Look at the picture on the other side where it says after trapeziectomy, we remove that painful bone. It's now an open space. You're not grinding on anything more, and that takes away your pain. Now, rheumatoid arthritis, as we spoke, is different. Again, now we're going to start looking at problems with these bigger knuckles. It becomes a problem because the knuckles sort of fall out of joint. Why? Because rheumatoid arthritis, let's go back to basics again. Rheumatoid arthritis is not a problem with your bones. It's a problem with the ligaments. So as you lose those ligaments because your immune system is attacking it and eating them and chomping and making them go away, the joints become unstable and begin to dislocate off to the side. And that's why you see such incredible deformities in rheumatoid arthritis, different than osteoarthritis. And then what happens, of course, it's like driving on unbalanced tires. Those fingers, now that they're dislocated and you try to keep using them, now the cartilage is going to wear away and you're going to get that pain from the arthritis. All right, so osteoarthritis, you lose the cartilage first. Rheumatoid arthritis, it's a consequence of having lost all those soft tissues because of the inflammation in your immune system.
Looks like Jeannie has a question.
Oh, Jeannie, hi. Thank you. You're on mute. I'll tell you what, I'm going to keep going, but if you unmute yourself, Jeannie, and you can just interrupt me at any time. Okay. So anyway, again, just a picture of a rheumatoid arthritis, how the fingers tend to slide off to the side. Fingers can go two directions. They go up into something called a boutonniere deformity or down into a swan neck deformity. Both of those deformities, because you either lose the stuff on the top of your finger or you lose the stuff on your bottom of your finger and your joint begins to dislocate into one direction or the other. And again, this is unique to rheumatoid arthritis. All right, so again, normal joint, rheumatoid, big, horrible, angry, red, swelling inflammation on the inside of the joint, which eventually leads away to the joints and wearing away.
Chat, maybe it's a question.
Am I muted?
No, no.
Okay.
She's able to. Jeannie, you're able to unmute yourself if you want to. There you go.
Am I unmuted now?
Yes, you are.
Wonderful. So going back to the joint removal of the thumb, do you lose any mobility of your thumb?
Actually, no. Actually, the opposite happens. The joint can become a little unstable because I've taken a big rock out of it, right? That bone that sits there is a platform for which your thumb rests on. And when I actually take out that bone, technically the thumb becomes a little bit floppy. That's actually where the healing comes in, is that I have to immobilize that for a little bit of a while so that the tissues around where I took the joint, where I took the bone out, have to solidify and create sort of a new platform for your thumb, but it's never quite normal. So one of the side impacts of this operation is that you lose a lot of strength in your gripping motion. And I always tell people, as long as you can still grip with your thumb, don't have this operation. When it hurts so much you can't grip anyway, now let me take the bone out, take away your pain. I'm not going to restore your strength, but I can take away your pain because you're not grinding on that bone anymore. So this operation is not an operation where you lose mobility, but you do lose strength.
So I was told, I've had steroid injections for the last 2.5 years, but now they're not working. I was told that there would be a joint replacement.
So there are joint replacements for the base of the thumb. However, none of them have a history of more than 5 years before they need to be revised. So with that in mind, you're absolutely right. If you go down to the city and you go to one of the quaternary hospitals where they do fellowship training and things like that, almost always somebody on the hand team has invented a new joint, a titanium ball, a ceramic ball. Gore-Tex was kind of key for a while. There are all sorts of implants for the thumb. And as someone once said to me, and this just rings so true, I think, when there's more than one way to do something, it means that none of the ways is really terrific, right? Because if there was a really terrific way or the perfect way to do it, we would all do it that way. And so that's sort of what's the truth is about joint replacements at the bottom of the thumb. They do exist, but none of them really have a long-term proven track record of success before they either crumble, fall apart, destroy the bone, or become stiff and painful. So with that in mind, yes, there are absolutely joint replacements for the bottom of the thumb, but the gold standard for treatment arthritis of the thumb is the procedure that I just described to you, which was actually invented way back in the 50s and 60s, simply taking the bone out of the thumb and leaving the space either empty or rolling up a piece of tendon, which I didn't go into the details. We roll up a little bit of a tendon and shove it in there like a pillow. Joint replacements, the man-made joint replacements made of titanium, ceramic, et cetera, have not proven to have as long a track record as that simple procedure.
So you also said that the healing process is 6 months. Does that mean that I'm immobile in that hand for 6 months?
No, when I say 6 months, I mean going back to doing everything without thinking about it. So,
Okay.
you know, most people would be in some sort of a splint for 4 to 6 weeks. And then after 6 weeks, still very restricted in your activities, maybe putting the splint on intermittently if you're going to be doing a little bit of extra activities. By 3 months, not having a splint on it anymore, but still being cautious and not really having your strength back and still hurting when you do certain activities. But by the time you get to 6 months, most people are back to doing everything with a minimal of pain and discomfort.
Okay. Thank you so much.
Of course. All right. So again, different than osteoarthritis, you'll see on the right side, that's a healthy hand with all these beautiful spaces between the bones. As I like to say, when we take an x-ray, it looks like there's a space between your bones. There's not. It's cartilage, right? So cartilage, because it doesn't show up on an x-ray, as that cartilage wears away, when I take an x-ray, we'll see the bones getting closer and closer and closer until they look like they're rubbing on each other. So on the right side here, the healthy hand, you'll see that there's gorgeous, beautiful spaces implying that there's great cartilage. On the other side, you see the bones flip-flopping off to the sides, classic with rheumatoid arthritis, because you lost your ligaments, and so the bones are all unstable and they're falling off one way and the other. And because they are falling off, now they're rubbing each other and they're wearing away, and that's why the joints no longer look like there's a beautiful, smooth space between them. All right. So stages of RA, it starts off with mild puffiness like you see on the left, then some early mild deformities, and then unfortunately late stage more progressive deformities. And unfortunately also with this inflammation, if you remember I said it starts in the soft tissues. Well, what else is a soft tissue besides the ligaments that hold your joints together? Are tendons. And the tendons, if you remember, are the ropes that move us. So in this particular person, you see that they're unable to lift up their ring and pinky fingers. If you lift up your own hand, you can do this easily. This individual is being asked to do that, and instead they can't get their ring and their pinky fingers to go up. Well, why does that happen? Well, that's because the ropes, the tendons that move your fingers in this particular individual have ruptured from the inflammation, that big ball of stuff you see on the back of their wrist. It has ruptured their tendons. They no longer have a rope attached to a muscle to move their fingers. Another problem that we can see is snapping. Well, what happens is that when you make a fist, if you see the rope of the index finger and the long finger, you'll see a cord running right over the top of the joint. But what do you see when you look at the ring finger? The rope is off to the side. It's sitting in the cavern between the ring finger and the pinky finger. That's a subluxed tendon. So that's another problem that can happen in rheumatoid arthritis. So why do you make an appointment to see a hand surgeon? Right? I just told you that, you know, if this is, the cartilage wears away, what are you going to do about it? Okay. If you have pain in your joints when you use them, or when you have rest, or you have swelling, or you have deformity, or you have stiffness, or you have popping, or you have snapping, or you have an inability to move normally, or you're struggling, these are reasons at least to go see somebody who can find out why that is happening, right? Is it happening because it's something that I can fix, like a ruptured tendon? Or is it happening because you have osteoarthritis, which I can't fix, but maybe I can make you more comfortable. Maybe I can provide you some tools to help you manage some of the functional challenges that you're facing because of the arthritis that you're struggling with. So my job is, the first thing is just to listen. I always say to my medical students, you have to listen to your patients, because just because somebody walks in with a really funny looking hand, right, with all kinds of deformities, don't make any assumptions. That person knows most of the time. You can't make their hand normal. What you're really asking them is, what are you struggling to do? In the course of your life, are you a tennis player? Are you a piano player? Or you just like to watch TV? Maybe you like to knit. What are the things in your, or maybe you can't wipe yourself. What are the activities that you're struggling to do? And why did that drive you to pick up the phone and then wait for a couple of hours to come see me in the office? Ask the person, what have you tried already? Did you already figure out? You don't need me to figure out. Motrin made you feel better, or Tylenol made you feel better, heat made you feel better, cold made you feel better, resting it made you, that splint made you feel better, right? Listen, what did this person already try so I don't waste your time? Then once I really listen to you, and I've heard from you what made you feel better, what didn't make you feel better, let me examine you, right? Look at your ligaments, look at your tendons, look at your joints, look at your bones, touch you, ask you to do certain tasks so I get an idea of what structures are working, what structures aren't working. And then usually take an x-ray. What do your bones look like, right? Now I figured out what you can and can't do physically. I've looked at your soft tissues by examining you, but now I'm going to look at your bony tissues by actually taking an x-ray. And then I try to put all that together and say, okay, based on your complaint, you don't feel like you have pain when you have to hold a book, all right? That's what's going on. Or you have clicking when you move your fingers. Oh, it's because of the tendonitis on the palm side of your hand. Guess what? I can fix that with a shot of cortisone. Oh, no, it's because your tendon is subluxing on the back of your finger. I can fix that, but that's an operation. All right. So again, we share information. I really listen to you carefully. I examine you carefully. I take some imaging, and then based on what you've come to me and asked and said that this defined as your problem, what can I try to do to make that problem less problematic for you? So in osteoarthritis, as I said earlier on, I can't cure it. It's genetic. It's a genetically programmed breakdown of your arthritis, but I can certainly give you some tools to make the joints less symptomatic for you. In rheumatoid arthritis, I'm going to send you to a rheumatologist. Why? It's an autoimmune disorder. I can suppress your immune system. Well, not me, but a rheumatologist, right? There are specialists. There's a huge specialty called rheumatology, where they can draw upon some blood tests that they draw on you and talk about what are some medications we can do to slow the progression. Again, they can't cure it and make it go away. It's an immune condition. But what they can do is slow down the process of your joint breakdown and your tendon breakdown so that you're functional for a longer period of time. As a surgeon, I can still also step in for things that the medicines can't control. But again, we're not curing, we're managing your symptoms and making you more functional. Now, what are some of the non-surgical tools? Well, simple things like using a can opener, an electric can opener rather than a hand can opener, putting wider handles on tools so you don't have to grip small things so that you can grip larger handles. Braces, there's a billion braces on the market. Don't waste your money. Usually as a hand surgeon, I can guide you into very specifically, you don't have to get it at my office. You can still order it on Amazon if you want. But let me at least not make you waste your time and money. Let's figure out what needs to be braced, what needs to be mobilized, so that again, you have braces that will help you rest your hand and braces that would help you be active with your hand. And then we want to go after the inflammation. Now I can do that with an occupational therapist. They have tools like ultrasound and deep heat and massage that can help make the inflammation go away. There's also pills. As long as you're not on blood thinners, as long as you haven't had bariatric surgery, as long as you don't have ulcers, we can go to oral anti-inflammatories, things like Motrins and Naprosins, Aleve, that sort of thing. Sometimes a topical steroid. There's creams that have steroids in them, and in the hand, because the structures are so close to the surface, sometimes an anti-inflammatory lotion over your skin can help with your joints and yet not bother your stomach. Oral steroids, going up a step. What's the difference between non-steroids and steroids? Well, steroids are much more powerful drugs. They do impact your kidneys a little bit more. They can affect your ability to fight infection. So they're more powerful drugs, but sometimes a temporary steroid to help calm things down and then get you on a non-steroidal can be helpful. And then of course, sticking a needle right where the problem is and flooding the area with a steroid injection, that can also be extremely helpful. Braces, as I said, there's lots of different kinds. These are 2 braces for basilar joint arthritis. And usually by examining you, I can guide you to one or the other. It's going to be more helpful for you. Sometimes that soft one is where we start. And as the disease gets more progressive, the rigid one is more helpful, and sometimes vice versa. There's all kinds of finger and wrist splints. And this was really just to show you how those splints can be used and how we, as specialists, can help guide you into not buying useless splints for you. And then once you do have the splint, at least advise you, one, on how to fit it correctly and use it properly. Sometimes just a Coban wrap. Arthritic joints hate being cold, absolutely hate it. So sometimes simply buying this cohesive wrap tape at your supermarket for $1 a roll can be helpful, and you can wrap the joint that hurts you in your finger. You don't want to wrap it all the time, but you know you're going to do something which aggravates it. You can wrap the finger temporarily, and that will also make you feel more comfortable. We talked about non-steroidals, and there's a billion of them, little exaggeration, but actually not by much. Lots of them on the market. And at the bottom line is they fall into just several small categories. I always like people to recognize that Advil, Motrin, and ibuprofen, please, they are all the same drug. Ibuprofen is the generic name. It also is sold by manufacturers by the names of Motrin as well as Advil. 200 milligrams of Advil is 200 milligrams of Motrin is 200 milligrams of ibuprofen. They're the same drug, all no difference. Aleve is the same thing. Aleve, naproxen, naproxen, all the same drug. And not a non-steroidal, but something that's in a lot of arthritis medications over the counter is Tylenol. And Tylenol generic name is acetaminophen. So if you ever wonder, if someone told you why you can't take non-steroidals, you can take Tylenol or acetaminophen, the cheaper generic component, which is fine. If you can't take non-steroidals, you want to avoid Advil, Motrin, ibuprofen, all the same drug, or Aleve, naproxen, or naproxen. Any questions about that? Because that's something I think can be very confusing. Okay. Other options, paraffin baths. It sounds silly, but again, that permeating kind of heat that you can get from sticking your hands into hot wax is extraordinarily soothing, extraordinarily soothing. And those simple cosmetic baths you can buy at any any drugstore or any Target or whatever are fabulous. And Christmas is coming up. So again, if it's your wax bath and your hand is the only one going into it, you can buy the paraffin and you can actually reuse it over and over again. Obviously, in a physical therapy setting where we use these, you put the wax on you, you leave, we swap out the wax for the next patient. But if it's in your own house, you can actually put it on, and when you're done with it, peel it and throw it back in the wax and reuse it again. And then, as we talked about a little more aggressively, a steroid injection right where the pain is. Where we put the needle is where the pain is. Usually what we try to do is we try to avoid going through muscles because that's where needles hurt. And the good news is most people have pretty bony hands, and we can really get a needle into your joint very easily and not with too much pain, because we don't have to go through like a lot of flesh like we do here, because that's where the needle hurts, is when it goes through flesh. When we put a needle into a joint in the hand, it's actually not terribly painful. Acupuncture. I don't know a lot about it, but I do know that patients swear by it. I always say something that's been around for over 2,000 years can't be all bad. It's got to have something rational. So again, I encourage my patients who certainly would think about trying it, try it. Go to an acupuncturist. Let them know where your pain is. And a lot of people do get very good relief from acupuncture. And then, of course, there's homeopathic remedies like using spices and foods. And that leads us to the anti-inflammatory food list, which you can look up and Google yourself. Again, I don't think that any of this all by itself is going to make your arthritic pain go absolutely away. But if you have whole body arthritis and you trend your diet towards these foods, you may require fewer anti-inflammatories and maybe less frequently, or at least you're not eating foods which flare you up, like red meat. We know will flare up arthritis. So again, if you stick to this diet, they're great foods anyway. I mean, it's for your heart and everything else. But these are low inflammatory foods, and you can indulge and not be concerned that it's going to aggravate your arthritis. And if medical treatments do fail to make you better, again, we do have surgical options. And when we talk about surgical options, again, just to educate you on terminology so that if you're talking to your doctor, you feel smart, right? Joint reconstructions, that's like a joint replacement, like everybody hears about knee replacements and things like that. Those are arthroplasties, plasties, we're putting you back together again, plasties, versus an arthro, that word arthro, joint keeps popping up. Arthrodesis, that's a freezing. A desis is a stopping of the motion. So a joint fusion is when we take a joint that used to move and we make it not move anymore. And because it doesn't move, it doesn't hurt. That works great, by the way, at the tips of the fingers. At the tips of the fingers, which guess what? You don't really need to move them very much anyway. And a fusion there can do a great job at getting rid of pain. So joint replacements in the hand, here are some examples of them. Wrist replacements, by the way, are very rarely used. And the reason for that is they fall apart. It's unfortunate, but that wrist replacement that you see right there, if you do anything more than wipe yourself, probably within 5 years, would rip out of the bone. So again, wrist replacements do exist, but we really very much reserve those for people who are fairly debilitated. However, these other smaller silicone implants you see, we call them rubber knuckles because exactly what they are. We go in there, we take out the bottom half of the one bone that's arthritic, the top half of the other bone that's arthritic, and insert this rubber knuckle. And guess what? Now you can move the finger. And then, of course, there's interpositional arthroplasty, which we've talked about already, where we physically remove the bone. You can see that white, angry bone. We've taken it out, and now there's an empty space there. And again, great news. It does a great job at taking away pain. And then fusions, as we talked about. This is a wrist fusion on the left side. We take that wrist and we fuse it like this. All right. The interesting thing is that pretty much people find out very quickly that you really don't need this all that much. People do miss this. Why? Wiping yourself. It's the one thing that someone with a wrist fusion really struggles with. It's the one activity in our lives where you tend to want to move your wrist down. So a wrist fusion in your dominant wrist does change that one behavior. But other than that, you can still twist, you can still move your elbow, and you can still move your fingers. So again, a wrist fusion can be very helpful for a painful wrist. And then you see some small joint fusions on the other side as well. And again, if your tendon ruptures, if you wake up one morning and you're like that lady who couldn't straighten out your ring and your pinky fingers, well, guess what? Come see your friendly hand surgeon and we will repair that for you. And sometimes we can't repair it. Sometimes we have to do a tendon transfer. That is, the tendon ruptured because it got worn away. We have these frayed ends and we can't stick them back together again. So we steal from Peter to give to Paul. And that is, we borrow a tendon, like you see these transfers here. We borrow a tendon from another finger that has two tendons. And like a good neighbor, we share, we bring it over, and they'll get you moving your fingers again. So again, if you wake up one morning and you can't straighten up your fingers, don't ignore it. Come see your friendly hand surgeon so we can take a look at that, and we can often address that, but that does usually require a surgical procedure. And then we talked about the tendon slipping off to the side. You can see again this woman's hand, the tendon is not sitting on top of the knuckle the way it's supposed to, it's sitting off to the side. So as a surgeon, I bring it back to the middle, and then the finger will work again. But again, it is a surgery. So in conclusion, there is no cure for arthritis, but the flip side of it is you can't make your arthritis worse by doing stuff. So people always say to me, well, if I do too much, will I make my arthritis worse? Well, you may make your symptoms worse because you've aggravated a joint that doesn't have a great lining to it, but you're not going to actually make the arthritis worse. You can't prevent arthritis other than not injuring yourself, all right, because that's that traumatic arthritis. But other than that, you can't prevent it. You can eat all the right foods. You can keep yourself in shape. You can take your calcium and your vitamin D. Rheumatoid arthritis and osteoarthritis are both genetic conditions that you're programmed to get. The rheumatoid arthritis, you can manage your symptoms with autoimmune suppressant drugs. And with osteoarthritis, we can certainly manage your symptoms with braces and medications and therapies and cortisone and sometimes surgery, but we're not going to cure the arthritis, I'm afraid. Thank you.